All right, good evening, everybody, and welcome to tonight's Facebook Live chat. Tonight, we're going to be talking about pelvic pain and IBD, and I know that this is a topic that a lot of people are interested in, but don't necessarily know a lot about, so I'm really excited to be able to provide you with some experts to hear from this evening. So did you know that some IBD patients experience pelvic pain or pelvic floor issues along with their disease? Oh, okay, we are still live, it looks like. Sorry about that. So this is an issue that affects both men and women, yet there isn't a lot of information available about it. So that's why we're hosting tonight's chat, to help you understand what pelvic pain is, why some IBD patients may experience pelvic issues, and how these issues are treated. So I'm excited to be joined by Dr. Tayyaba Ahmed, Kara Mortifoglio, Dr. Neilanjan Nandi, and Tina Aswani Omprakash. Dr. Ahmed is a pelvic pain physiatrist with pelvic rehabilitation medicine in New York. Kara is a physical therapist who has experience working with people with pelvic pain issues at Solstice Physiotherapy in New York. Dr. Nandi is a gastroenterologist at the University of Pennsylvania in Philadelphia. And Tina is a Crohn's patient who's dealt with pelvic pain issues for many years and writes the blog Own Your Crohn's. Dr. Ahmed, Kara, Dr. Nandi, and Tina, thanks for joining us today. And I'm excited to chat with you all about this topic. So for the next 30 minutes or so, we're going to answer some commonly asked questions about pelvic pain and IBD. We want this to be interactive, so please comment below, tell us who you are, where you're from, and if you've experienced any pelvic pain issues in your IBD journey. Couple quick disclaimers before we get started. The information provided during today's chat does not represent the official position of the foundation. Always consult with a physician when making changes to your IBD treatment regimen. And as usual, tonight's topic is pelvic pain and IBD. If you have questions about other topics related to Crohn's or colitis, we're not going to have time to get to them during tonight's chat. But we do encourage you to contact the IBD Help Center with your questions at info@crohnscolitisfoundation.org or 888-MY-GUT-PAIN. So now with all of that introductory stuff out of the way, let's jump right in. Dr. Ahmed, what is pelvic pain and or pelvic floor dysfunction, and what types of conditions can result in pelvic floor dysfunction?
So pelvic floor dysfunction is a very broad term. For people with pelvic floor dysfunction, that could be a very loosey-goose type pelvic floor that's weak and hypotonic. It can also be a tight and hypertonic pelvic floor or overactive pelvic floor. So, we typically think pelvic floor, we think Kegels, we think grandma in Depends diapers. Those are the classic scenarios that we're thinking, or the pregnant woman who's had 2 children and she's feeling like she can't do jumping jacks because she's going to pee herself. That's not necessarily the scenarios that we're actually seeing in real life with people who have bowel issues or a history of hemorrhoids, anal fissures. There could be those postpartum women, but in this scenario, you could have pelvic floor dysfunction as a result of multiple surgeries. You can also have pelvic floor dysfunction as a result of stress, anxiety, or different procedures that are happening below. So it happens in men and women. And so technically chronic pelvic pain is when you've been having an issue or pain in the pelvis for over 6 months. We need to know what the diagnosis is, whether it's a hypertonic pelvic floor, is it underactive, and take it from there and how we're going to treat it.
Dr. Nandi, how can pelvic pain or pelvic floor dysfunction happen in Crohn's or ulcerative colitis patients? Is it a common issue? Does it only occur in surgical patients, or can it happen in anyone with IBD, male or female?
This is a great question. And, I want to take the opportunity to speak as a Crohn's and colitis physician to the patients and caregivers and family members who are listening to this broadcast. This is a very common and underdiagnosed phenomenon. So pelvic pain and pelvic floor dysfunction are separate but not mutually exclusive. You can have one or the other or both, but it's underdiagnosed. And it's something that your gastroenterologist probably, I can safely say, didn't get good training on, didn't get good education on. It's not something, and I see a lot of nods, it's not something that you're taught in medical school, maybe a page, right, out of a million pages that you're learning. So this is uncommon knowledge. And fortunately, there are specialists like Dr. Ahmed and Kara who dedicate their careers and their practices to helping patients. So as you learn through this webinar, I want you to realize that you might have it, and you probably do. And you may have it before you were diagnosed with IBD. There's also a lot of learned behaviors that can contribute to pelvic floor dysfunction that manifests with constipation or improper defecation. But when we get to our Crohn's and colitis patients, we have to think about why are our patients at risk for this? And it may or may not be obvious to you. When we look at a nice, beautiful anatomic diagram of the intestine, you pull up Crohn's or you pull up UC and you look at it on Dr. Google, you'll notice all the beautiful organs that are in there outside of the intestine. They look so beautifully organized, but in reality, everything is packed in, and much so in the pelvis. It's a very tight space. So if you're an ulcerative colitis patient, you know that inflammation begins at the rectum and then goes up through the sigmoid up the left colon. If you have Crohn's of the small bowel or large intestine, then you know that much of the abdomen or small intestine and beginning of the colon is down there in the pelvis. You can get inflammation in the intestine that transmits that inflammation to other organs, the bladder, the vagina, other pelvic organs. This includes males as well too. You can have scars that develop anytime that you have surgical interventions. So if you've had surgical resection, you get scar that happens outside the intestine that can connect to other adjacent organs. That's why if you had a bowel obstruction in our community, you hear doctors talking about adhesions. Well, what the heck are adhesions? It's scar. And scarring can occur from surgical interventions, as I mentioned. It can also occur from chronic uncontrolled inflammation or the trauma of having pelvic infections. As those infections are treated, as antibiotics get rid of them, you go to interventional radiology, you get stuff drained, you get catheters placed. All this does create scar, and that burden doesn't go away. It leads to improper contraction and relaxation of muscles and tendons, and that is me simplifying it. But this can, again, lead to pelvic pain, nerve entrapment. It can also lead to like I mentioned, incontinence, constipation, diarrhea. The problem in our community is all those symptoms you may think are a manifestation of your underlying IBD. And the way a physician like myself distinguishes whether you have whether your symptoms are from IBD or something else is by imaging and scoping. We take a look, and if we do not see that the tissue is healed, then we think of this whole checklist. And on that checklist, outside of infection, adhesions, and the list goes on, should also be pelvic floor dysfunction. So oftentimes things look good, things look healthy, and you can still have pelvic floor issues.
So Dr. Nandi, when do you refer patients out to see a specialist? Based on what symptoms?
It's a pretty low threshold, to be honest. We talked about men and women, and this doesn't distinguish between the genders. One other thing to know is about 50% minimum of those patients who've had an ileoanal pouch have been shown to have some form of pelvic floor dysfunction. I wonder, Dr. Ahmed, have you seen that in your practice, that patients with pouch surgeries have had significant pelvic floor, right? So for both women and men, if they've had any type of if they're going for a surgical intervention, such as surgery, I may give them some education and ask them to see if the timing works out, a pelvic floor therapist. In women, let's say they're not going for a surgical intervention, but they're having a baby, and I do this for non-IBD women too. I ask them to go see a pelvic floor therapist before they have the baby, and then certainly after. Any type of surgical trauma or any type of prepartum or postpartum female, I will recommend. And then my men who have had any type of erectile dysfunction post-surgery, I may ask them to go see a pelvic floor therapist in addition to a urologist too.
So we just got a question on Facebook from Amy who asked if the condition is more common in one gender versus another. So I know it can happen in either, but is it more common in women versus men, or is it kind of equally split? And this can be for Dr. Ahmed or Dr. Nandi.
In my practice, I see more women than men, but that's because there's something called endometriosis, and that's 1 in every 10 women. And so there's definitely a higher number, incidence of women with, obviously, because of the endometriosis.
Yeah, and I would agree that I think that the people who are the gender that stereotypically are more likely to talk about this or seek help are female. And, you know, jokes aside, kind of, men are stupid and men are proud. And it's not machismo to talk about this. It's hard for women to talk about it, let alone men. I only through relationships well after training did men start opening up about it. And it's not something I know how to treat, but I know how to recognize it and how to refer to professionals. But men have it too. I just don't think that in the questionnaires and surveys that we're capturing enough men to speak up about it.
So Tina, I know you've experienced pelvic floor dysfunction. When did you first realize something was wrong, and what kind of symptoms were you experiencing?
So I actually think I had pelvic floor dysfunction for many years prior. So I was finally referred over to a pelvic floor physical therapist in 2016, so just 4 years ago. But I had 20 surgeries prior to that. And I had J-pouch surgery, and I noticed that I had a lot of problems with incontinence. In general, like it felt like there were stools stuck. I had a lot of issues with peeing. With all the fistulas that I had 5 rectovaginal fistulae. So with that, like I developed so many issues with peeing, and they weren't always UTIs, even though they felt like the worst UTIs. And I think that was a telltale sign that no one picked up on. And I think Dr. Nandi's definitely ahead of the curve as far as GIs go, because I was never referred by my GI or colorectal surgery. And I mean this, you know, as nicely as possible. It was my OBGYN who finally referred me. So I was having significant peeing problems. And what was happening was I developed a lot of scar tissue in my pelvis that was actually pushing down on my bladder. So there was this scar tissue, this adhesion that had filled up with fluid. It's called a peritoneal inclusion cyst. And there were 2 of them sitting on my bladder, pushing my bladder, and it was significant pain, and I was peeing like every 5 to 10 minutes. So that's when I was referred to pelvic floor physical therapy. And it took a few weeks, but I kept this log, this journal that basically monitored my symptoms over the next several weeks and months. And I noticed my frequency went down to every 2 hours, every 3 hours of peeing. And that's what I understand with bowel movements as well. So for me, at that point, I already had Barbie butt. So my bottom was stitched. But I also had developed something called this phantom rectal pain. That's how my surgeon had referred to it. And it would feel like this urgency through my bottom, but my bottom's closed. So that kind of rectal pain, I know that's associated with pelvic floor dysfunction. So that's something else that's been helped with pelvic floor physical therapy and with physiatry, which I know Dr. Ahmed will go into and Kara will go into a little bit more about those details. But that's how I first was like, okay, there's something really wrong. And I was having so much pain, and not just with the peeing, but all around, lower back, my bottom, abdomen, pelvis. And my doctor would be like, but you're in remission, you know, and everything else is fine. It must be IBS. It's not just IBS. It was pelvic floor dysfunction for me. So I think these are things that we have to tease out and coordinate our care with different providers to make sure we're getting the treatment. And that's why I think it's important to bring up this topic of pelvic floor dysfunction. If your GI or colorectal surgeon hasn't brought it up to you, definitely bring it up and see if you can get a referral out.
So Tina, did you encounter any issues finding someone who had experience treating pelvic floor dysfunction in IBD?
You know, I live in New York, so it was definitely easier, but 4 years ago, this specialty didn't seem to be as common as it is today, or it's definitely budding now. I was initially referred over to my hospital system. I didn't find the care to be as robust. My gynecologist finally just recommended me over to an out-of-network provider, and luckily I have decent out-of-network benefits. And I was able to see a physical therapist and physiatrist in that way.
Great. So Dr. Ahmed, how do you treat patients with pelvic floor dysfunction? And does treatment differ among men, women, or non-binary individuals? Ooh, I think you might be on mute.
Sorry about that. So I have a poster, but I don't know if I can show it to you like this. But the pelvic floor, I don't know if you can see this for everyone at home, between the men and the women, it's very similar. So if you notice the pelvic floor between the pubic symphysis and the tailbone, man, woman, the bladder, prostate, uterus, descending colon. So obviously it depends on if the patient's had a surgical procedure or not, but majority of patients, their pelvic floor dysfunction is treated in a similar way, despite the difference in the male and the female genitalia. That being said, males and females will present a little bit differently based on their symptoms. Obviously, sometimes when people have pelvic floor dysfunction, they may not necessarily present with the trifecta of symptoms affecting the bowel, bladder, and the colon, bowel and the sexual organ or reproductive organ. So for some women, they might have pain with intercourse and urinary symptoms and bowel issues, constipation, diarrhia. You know, it's hard to say. So it depends on what we're focusing on. So now, generally speaking, majority of patients who have pain are going to present with some sort of tightness in their pelvic floor. We always start with pelvic physical therapy. That's basic, you know, a little bit of internal, external work depending on the patient and depending on where. So females is a little bit easier because we have 2 holes, so there's 2 entrances. Males are a little bit harder in that situation, especially if they've had a surgery. And I'm sure Kara's going to talk about how she gets around that if they have had a procedure. But we were saying, so treatment will be depending on the patient. So, you know, they may tolerate suppositories for muscle relaxation. They may benefit from some oral medications for their nerves. So as Tina was saying, that a lot of patients may feel that sensation of something in their rectum, whether like they're sitting on a golf ball or that urgency or something being there, but there's nothing actually there. That could mean the pudendal nerve is involved. And when that happens, a lot of patients have neurogenic inflammation in that area. And that's not necessarily mean that there's pudendal nerve entrapment, which is a bigger and scarier diagnosis for a lot of patients. But you can still have pudendal nerve issues without necessarily having an entrapment. So a lot of people want to get imaging to see if is it entrapped, because if you go on Reddit and it's telling you all these terrible things about pudendal nerve entrapment, you want to see it on a diagnosis. Don't do that because it's not great. There's not a lot of good information out there. What's most important is starting to treat it, because whether you have it or not, on imaging, the treatment is the same. And so getting into a pelvic physical therapy, getting the proper appropriate diagnosis, whether you can find a physiatrist or a pelvic pain specialist to appropriately diagnose you. The most important thing is the diagnosis, and that has to be done with exams. So as great as telemedicine is, that we can't do that over a computer. And then, depending on the person, we might do some creams, we might do some nerve blocks, we might do some injections to the pelvic floor, including trigger point injections. There's also Botox, which is used in the last resort, usually. Yeah.
Okay. So Kara, can you talk to us a little bit about physical therapy and what modalities you use to treat pelvic floor dysfunction in IBD patients specifically?
Yeah. So with physical therapy, we're going to look at the whole body. So especially with IBD patients, we definitely want to take a look at their abdomen because obviously there could be scarring from any surgeries in the past. So we'll definitely do some soft tissue work and massage to the abdomen, also teaching the patient how to do that themselves. We'll feel around in the tissues around the pelvic floor, so in the gluteal muscles, the inner thighs, and then you can touch the pelvic floor externally without doing anything internally. So if anybody's nervous about doing anything internally, or for males, if they're unable to tolerate it rectally, we can work on it externally. So around the base of the penis or around the vagina, we can work as well. So there's some external massage we can do. And internally, if the pelvic floor muscles are tight, we can do some internal stretching. So it's just basically me placing my finger intrarectally or intravaginally and applying pressure and doing massage to the muscles. And then we work on with the patient's coordination. So teaching them how to contract, relax, and open up. We can do biofeedback with either an internal sensor or external sensor so the patient can see what they're doing with their pelvic floor. Because a lot of times, if you've been in pain for so long, you're probably keeping your muscles tight most of the day. So it's trying to figure out, what you're doing on a day-to-day basis. And then we'll also go over stretches, strengthening exercises, breathing techniques, posture, as well as there are some tools that you can use at home to stretch the pelvic floor, such as a dilator or a wand. So all of those are different modalities and things we can do to help patients. And it really does help a lot.
So why is it so important to do these exercises under the guidance of a medical professional? And how can patients continue the therapeutic process at home?
I think it's important to come in and get your pelvic floor checked, because if you go see somebody and they're just recommending for you to do Kegels, you could be doing more harm than good, because those muscles are, in most cases, they're tight. So that's just going to make it worse. So I think it's helpful to get guidance, because we really want the pelvic floor to be relaxed while you're doing some of these exercises. So we're pretty specific with you when we're going through the exercises and cueing and breathing and how we want you to do it. So that's one way to continue the PT on your own at home. And then those tools that I was talking about, like a dilator or a wand, you could use on your own. And we can show you how to use it, because it can be a little bit scary to try to do it on your own. So having some guidance and having us show you how to do it can be really helpful.
Dr. Ahmed.
I was going to say one thing that Kara was doing so well in illustrating that I hope that patients can take away is that you're learning skills here. And, a common misconception that I've heard is that people think that they have to see the therapist indefinitely. And you may just need a few sessions and may need some tune-ups or check-ins for sure. But there's a lot of skills that you can learn to empower yourself. And, we've talked about a lot of these types of therapies. You may notice that, and Dr. Ahmed, if you have different perspective on this, oftentimes surgery does not make a lot of pelvic floor issues better. There's a time and place. Sometimes it can make it worse. So that's good news in the mindset of our patients, I feel, because going to a pelvic floor therapist, you can know they're looking at non-surgical ways, right, to help you feel better. So remember, this is not necessarily lifetime therapy. These are skills. This is a way of empowering yourself with skills you can do at home in your own privacy for the rest of your life.
And I just wanted to add to that, I couldn't agree more. As somebody who's been sort of in and out of pelvic floor physical therapy and goes mainly for maintenance and tune-ups, now it's definitely been life-changing for me. I think, yes, was I squeamish in the beginning? Hearing Kara and Dr. Ahmed talking about the internal work or the work to your genitalia. Yes, it's scary initially, but I feel like you get over that ick factor really quickly when you start to see results. And I think we have to remember, for me, it was really crucial not to be on opioids or narcotics. And I was on them for way too long. And this kind of pain was just not going away. So having physical therapy be a modality to reduce my pain, give me that quality of life back, have me start exercising again, it was like a whole brand new world that opened up for me. So I think keeping that in context is really important as a patient as well.
That's really good advice, Tina. And I actually have a follow-up for both you and Kara, which is, I know for a lot of patients, staying on track with their regular treatment can be a burden and difficult for them. What do you recommend to keep patients motivated to stick with doing their exercises at home outside of treatment?
I think that it's important to know that even a little bit will make a big difference. So even just maybe trying to stand up during the day when you're working could make a world of difference for your pelvic floor. And maybe even doing just one stretch once a week might really help a lot. So I think that something is better than nothing. And you don't need to have a whole elaborate home program of like 100,000 exercises, but like maybe you do one and that really helps. Or maybe you have a foam roller and sitting on that, you know, really, really helps. So it just, you know, little changes can make a big difference.
I think for me, it's funny that you asked that, Rebecca, because within like a few days of me not doing my exercises, and believe me when I say this, I start to have pain. So it's one of those things like, do I want to be in pain or do I want to keep up with this? So I obviously choose the latter. And if that means I'm sitting here in front of my TV, foam rolling, that's what it means. Or, you know, doing like some yoga poses that my physical therapist has taught me, that's what I'm doing, because you got to fit it in somehow, some way, because it gives you that quality of life back. So that's the way I look at it.
So Dr. Ahmed, if patients continue to experience pelvic pain despite doing physical therapy, what do you recommend?
So that's when usually I have to add some stuff in. So that's usually when we'll add in suppositories if they've never used them before, to help get those muscles loosening up along with the physical therapy. Sometimes physical therapists will refer a patient to us because they need a little bit of help because the patient seems to be plateauing. And then sometimes if they have already been doing suppositories, we might add in trigger point injections. So close to what you guys were saying, when we do our injections, we'll do a few on each side, and then we'll tell the patient for the next 6 weeks, you have to continue the exercises with your physical therapist, and then you can come back. And you know, most of our patients, you know, most patients with IBD are okay with procedures or injections done in their pelvic floor, but it's kind of like, okay, I can yell at you and tell you you have to do your exercises, otherwise you're going to be back in this office getting injections in your rear end, and that usually drives people to continue their exercises, which I tell them every day. It's 10 minutes, maybe 10 minutes of yoga for a few days a week. Obviously, I ideally like every day, but I'll take what I can get.
And just to add to what Dr. Ahmed is saying, so I started plateauing maybe a year and a half ago after doing really well in physical therapy. And that's when I started to see physiatry. And while I was scared to get some of these pelvic floor injections, and it hurt, within minutes, a lot of my pain was gone. And for me, just all the scarring that I have, all the scar tissue, all the manipulation I've had done, it is something that I find that I have to usually go for every 6 months regardless. And then I go back into physical therapy and I'm so much better. So I've definitely used, like when flying on a plane or sitting in a car long term, like, you know, for several hours, I've definitely used like some of the suppositories that Dr. Ahmed is talking about. I've used like Valium suppositories, baclofen, those kinds of things, and they've really helped, in addition to some of the creams that have been prescribed topically to help with pain.
So Tina, I know you hear from a lot of patients on a variety of things. So I'm curious, what have you heard from patients who have pelvic floor dysfunction, and what challenges do they commonly face?
So I'm trying to do more and more education about this. And a lot of times patients will just reach out and be like, this is a thing. Or they'll be like, is that what my pain is? So I'll get questions like that. And then I'll get questions like, oh my God, how do you do this? Like, how do you find a provider? Who do I go see? How do I talk to my doctor about this? This is so weird to talk to my doctor about. So those are sort of the beginning types of questions that I get. And then a lot of times I end up, especially if they're in New York or a major city, I think like Dr. Ahmed has a practice that seems to be growing around the country called pelvic rehabilitation. So I know like I've sent, you know, people who don't even have IBD reach out to me, you know, might be postpartum or whatever. And I'll be like, you know what, there's an office in Baltimore, maybe look into that. And, you know, I will reach out to my providers and be like, do you know of physical therapists, or do you know of a physiatrist in this particular location? Sometimes I'll do a little research for them too, for the patient, and see. I do get a lot of messages internationally. This is not something that's treated much internationally. And there's a lot of patients having trouble across the board with a variety of different conditions, and especially IBD. So I'm hearing all sorts of things, but usually when those patients go in for physical therapy, and usually add physiatry, they're doing much better. And I will hear back from them within 2 to 3 months and be like, oh my God, this changed my life.
So Kara and Dr. Ahmed, while pelvic floor dysfunction can affect anyone, I'm curious, how does it affect pregnancy and fertility?
Okay, so just how we kind of spoke previously, certain people, are we talking in the IBD or just in general?
I think in IBD first, but also just in general.
Okay. And depends on the majority of, if you already have a pre-existing pelvic floor dysfunction, there's a good chance you're probably going to have pelvic floor dysfunction after you have a child. That doesn't necessarily mean you will, but there's a good chance, especially if you have pain during your pregnancy. When you're pregnant, your relaxin hormone will relax your pelvis, and your SI joint, which is between your sacrum, my model for Instagram Live, your SI joint over here will actually, cause a lot of pain. And so sometimes people will feel like it's their hip, but it's actually their SI joint. The pubic symphysis can also separate a little bit, and depending on how much it separates can cause pain. And a lot of people will have pain in those joints, but those people can also present totally fine, and then after they have a traumatic delivery, they can actually have their worsening of their pelvic floor dysfunction. So IBD or not, a lot of pregnancy is no joke, and it's a lot of changes on your body, and depending on the way the hormones are and how you respond, some people actually feel really good during their pregnancy, and some people will feel not so great. In terms of fertility, I'm not sure how it affects IBD. Maybe Dr. Nandi would know that, but for what I see, if there is concomitant in endometriosis, that would definitely, because it's an inflammatory disease, would affect the ovaries and and therefore implantation and cause infertility. So that definitely has to be diagnosed much earlier. Kind of like what Tina was saying, when people have so many overlapping symptoms, it's very often that these pelvic floor dysfunction, endometriosis are kind of blamed on IBD, or it's just because of the overlap in the constipation and the abdominal bloating.
I would say I agree with what Dr. Ahmed was saying. And I think it's important for us as an IBD community, particularly women, to distinguish between fertility and fecundity. And fertility is really where a sperm and an egg can get together and make an embryo, a zygote, that embryo, fetus, baby. But fecundity is having a hospitable environment. So you can have intact fertility, and IBD patients by and large have normal fertility. If you join the egg and sperm together, voila. But is the environment hospitable? So when you have active disease in the pelvis, where intestines are adjacent to ovaries and fallopian tubes in the uterus, that inflammation can push over from the intestines to the reproductive organs. And that inflammation, that cytokine storm, you've heard the word cytokines a lot because of the media, because of our meds and COVID. That cytokine storm prevents the egg from implanting or having a hospitable environment. Also, scarring that can occur from any of the reasons we mentioned before around the fallopian tubes can change the pH, the flow of fluid from the ovary down the fallopian tube to the uterus, and that can also create poor fecundity. So it's important to understand that IBD, especially active, or a history of uncontrolled activity or surgery, can lead to a decrease in fecundity, but that fertility is likely preserved. There are many things that Dr. Ahmed mentioned that can be mistaken for IBD or IBS, such as endometriosis. And the pelvic floor dysfunction itself may be independent of the IBD, may be a consequence of IBD or delivery of a child. So they're separate, but by and large, I wouldn't say that pelvic floor dysfunction alone affects the fertility, but can certainly have complications that affect the ability to carry a successful embryo through gestational 9 months to a successful delivery.
Great. So, Dr. Nandi, if an IBD patient is experiencing pelvic pain or pelvic floor dysfunction, what's the best way for them to get their gastroenterologist or other doctor to refer them to a pelvic floor physical therapist or specialist?
What you're doing right now. So just by learning about this concept is probably where you have to start. So if your own gastroenterologist hasn't brought it up, right? Perhaps they haven't found the right opportunity, or they didn't know, or didn't come to mind. Now you can voice it, right? We're giving you some of the vocabulary, some of the lexicon, some of the signs and symptoms, and you can go out and read more. And we can certainly put down some resources to read more about pelvic floor dysfunction. But now that you know about it, it should be as simple as bringing it up to your doctor. So if you put the idea in their mind, I'm hoping that they will go with the flow and go ahead and order the right type of testing, or review the history with you. And if testing is indicated, great. If just coming to go directly see a pelvic floor physician or therapist, wonderful. Now, what do you do about the clinician who may be dismissive, right? And I think that's the common, unfortunately, sadly, what I hear is the more common scenario. And I think that's what I've heard here, which is there are a couple of websites and resources where you can find a database of therapists. And oftentimes you can refer yourself. You can even call your insurance company. I'm hoping, Kara and Dr. Ahmed, you can provide some great resources or databases for our patients to find their own pelvic floor therapist.
Yeah, so there's 3 websites that I'll share with you. So Herman and Wallace, they're a pelvic floor education provider. They have a directory, as well as the American Physical Therapy Association. If you look on the pelvic health website section of that, they have a directory. And then also pelvicguru.com has a directory as well. So most of us PTs are listed in hopefully all 3. And in some states, there's direct access, meaning you can go visit a PT without a referral, usually for the first 30 days, and then you'll need one thereafter. And I would imagine that you find a PT and they'll probably have a doctor like Dr. Ahmed, or maybe if there's no pelvic pain physiatrist, they may know a good gynecologist or a good urologist that might be able to help. So usually it's like a pretty close knit network. So, finding a PT or a doctor that's within that, they'll probably have a lot of referrals for you.
And Kara, that was a great point. This is a multidisciplinary chronic illness. And if your gastroenterologist is unable to know who to refer you to, then Kara mentioned there are physicians who have specialized in urogynecology in women or men, and guaranteed they know exactly who to refer you to and how to seek them out. So you don't have to just go to a gastroenterologist to get the right lead.
And we'll share the links that Kara just mentioned in the comments below after the chat, so that anybody who was looking for those resources will be able to access them.
There's also International Pelvic Pain Society, and you can find physicians and I believe therapists on there as well. And you can find it by searching for their location, and majority of them are on board with everything we've talked about.
Great. Dr. Ahmed, does insurance cover treatment for pelvic floor dysfunction? If not, do you have recommendations on how patients can manage the cost for treatment?
So it really depends on where they're going and the provider they're going to. Depending on the location, they may take in-network benefits, they may take out-of-network benefits. Unfortunately, with the pelvic pain world, it's hard. It's a very invasive world that we're living in, where physical therapy has to be done internally. You need a lot of time with the patient. An initial consult that I do with the patient may be an hour and a half. In that amount of time, some doctors will have seen 4 or 5 patients, and I'm still sitting for the first for an hour. So it really depends on who you're going to. In a lot of academic centers, insurance does cover it, but as Tina said, sometimes you may not feel very special, or you're not getting that attention that you need or want, and then in those scenarios, patients can go out of network. For patients that in terms of treatment, once you have seen a provider, providers are responsible for your medications, your treatments as much as you can, and cover. And as physicians, we don't get paid for medications, obviously, so that's a separate issue for patients. So medication wise, and then physical therapy wise, Kara, I think you can talk about in-network versus out-of-network physical therapy.
Yeah, it's a similar situation, depending on it. I mean, in New York City, the in-network providers typically can't spend as long with you. So it could be anywhere from like 10 to 20 minutes with the PT versus I'm an out-of-network provider, so I can spend usually 45 minutes, sometimes more with the patient. So I think for pelvic health, I mean, I think 45 minutes is really helpful to make sure that we go over everything we need to. And oftentimes, sometimes you'll need fewer sessions instead of having to go in twice or 3 times a week with an in-network provider. Unfortunately, I wish that insurance paid us better to be in-network.
I think for me, like just seeing out-of-network providers, the quality of care has been so much better in the pelvic health world. But like I've had to make sure that I have a decent plan that covers a decent chunk of out-of-network benefits. And between that and the biologics that I take, I make sure that I have a top tier plan that can cover these kinds of things so that I'm not out a ton out of pocket on my own. So that's something that I look into when I buy into a plan, is to make sure that there's good out-of-network benefits, because it's not just this, there's other sort of things that you need that might be out-of-network.
And if there are people who are watching who do have insurance questions, we do have a lot of insurance resources on our website, and you can also always contact our IBD Help Center, who can help you navigate through the different plans and options that are available out there for you. So last question, this is going to be for all 4 of you. Do you have any final words of advice for IBD patients who think they may be experiencing pelvic floor issues or pelvic floor dysfunction? We can start with Tina.
So I have a couple things. I think if you've heard about this topic, you hear a patient advocate like myself talking about it, definitely reach out, ask about their experiences. I think it's worth talking to your doctors about it. If your GI or your colorectal surgeon may not be as aware of it, as we've said, definitely talk to your urologist or gynecologist about this. Even your PCP, you never know who's going to have knowledge about this and how you can get the help that you need. But unless you ask, unless you speak up, you're not going to be able to get that help. I understand that this is potentially a very stigmatized topic. It's hard to talk about, but if we're talking about our bowels, I feel like this is something that we need to address, because living in pain is not a way for us to continue to suffer. So I definitely urge you to speak up about this if you are struggling.
Kara, do you want to go next?
Yeah, so I think, we were talking about how underdiagnosed this is. I think, so many more people have pelvic floor dysfunction than we realize. So, now that we've talked about it and people have heard, if you even suspect it, it might be worthwhile to get it checked out, because the sooner you get it checked out, the sooner you're going to feel better.
Dr. Nandi?
Similar to my colleagues here, which is, again, IBD community, IBD family. If you think that you might have it, you probably do. It's difficult as an IBD patient not to have it. You have had inflammation, if you've had surgery and or a baby, okay? If you've had inflammation or surgery, if you're just human, okay, you may have some component of pelvic floor dysfunction. So like Tina said, like Kara said, like Dr. Ahmed said, bring it up. This is the beauty of our community. This is where you start gaining that new knowledge that this exists, and you just have to speak up. And if you need support, you have questions, you know exactly who to come to. You come to the Crohn's and Colitis Foundation, and I'll just put all of us out there. I know everyone here is on social media, and we answer questions all the time, direct people in the right direction. Reach out to any of us because there's help. This can be helped. This can be improved, and you deserve that.
My advice is going to be, I guarantee you are going to be dismissed at some point by some physician or nurse practitioner or someone. And even though they're going to tell you that it's not pelvic floor dysfunction, it can't possibly be, it's just your Crohn's, don't worry about it. If you are on the medication and you're still feeling away, or if you have pain with sex and you're avoiding sex because of it, or you're having urinary symptoms, keep asking, keep going to different doctors and different, find yourself a therapist, and you'll eventually get the diagnosis, I promise you, assuming, you go to the right person. Just keep trying, because you yourself know when something's normal and when something's not.
Great. Well, thank you everybody for joining us for tonight's chat about pelvic pain and IBD. And a big thank you to Tina, Kara, Dr. Nandi, and Dr. Ahmed for taking the time to chat with us tonight and for their commitment to helping the IBD community. If you have more questions about pelvic pain and IBD or IBD in general, again, we encourage you to contact our IBD Help Center at info@crohnscolitisfoundation.org or 888-694-8872. Have a great night, everybody.
Thank you.
Night.